everybody could hear me. I just wanted to welcome everybody and thank the Carney family for inviting me to speak at this wonderful event. Tonight I just wanted to share a little bit about Marissa's story. I'm sure most of you are already familiar with her story, but there may be a lot of details that you don't know about. So the big question that had been presented was, what caused Marissa at the time of, 4 years old to go from being completely healthy, as you can see in her pictures here, when she was 3.5 years old, next summer at 4.5 years old, to gain so much weight and need to have ventilatory support in such a short time. So when Marissa was born, she was a full-term baby. Everything was going normal with the pregnancy, and up until she was 4 years old, she just had some ear infections and colds, nothing unusual for a young child. It's really nothing remarkable in the family history. Marissa was developing completely normally. She met all of her developmental milestones on time, walking on time, talking on time. She even was toilet trained at a relatively young age at just 2 years old. So it was a bit unusual when she started to go to the bathroom very frequently and had some urinary, accidents during the day, which prompted Mom very astutely to bring her into the pediatrician. The pediatrician did urine tests, made sure there was no infections and everything looked okay. But thankfully, her pediatrician noticed that it was, a bit unusual. Over the past month and a half, 2 months, she had gained 6 pounds, which for a 4-year-old child is quite a lot. And Mom had noticed that her, belly looked bloated and she was having some swelling and itching to her feet. That prompted the doctor to send her for an abdominal ultrasound, which just showed a little bit of fullness in her left side of her kidneys. Thankfully, nobody was satisfied with that answer, and she went for an abdominal MRI, which showed a mass in her adrenal gland. She also had blood work done at that time, which at that time showed that her sodium, one of the electrolytes in our body, was much higher than it should have been. And there was some concern because one of the stress hormones in our body was elevated, cortisol. Because of the swelling that had been noticed, she was seen by cardiology, and there she had a normal EKG and echocardiogram, so it looked like her heart function was okay. Because of the mass that was seen on the MRI, she was sent over to Cohen Children's Hospital for a hematology oncology consult. There they did blood work to see if this mass in her adrenal gland was making hormones. One of the hormones, that cortisol in particular, can cause somebody to develop something called Cushing's syndrome, which does present with rapid weight gain. However, she had additional testing done that ruled that out. One of the other disorders that we treat in endocrinology is called diabetes insipidus. Most of you are probably familiar with diabetes mellitus, which is glucose or sugar diabetes, but diabetes insipidus is water diabetes, where the person is urinating frequently because they can't make a hormone to control their urinary frequency. However, the tests didn't look like that was what was going on with Marissa. They did an MRI for brain, which was normal. Because of the adrenal mass, she underwent surgery to remove the left adrenal gland, and they found out that she had a tumor called a ganglioneuroblastoma. And post-operatively, those labs that had been abnormal were starting to normalize. So one of my biggest questions that I had when I first met the Carney family, because I had the luxury of Marissa coming to meet me for the first time already carrying the diagnosis of ROHHAD, was how in the world did this doctor come up with this diagnosis? I honestly hadn't even heard of it. And Mother quite honestly told me that Dr. Fish and the other hematologist at LIJ had just done a journal club on ROHHAD, and they thankfully put the pieces together and contacted Dr. Weese-Mayer, who's the expert in this area. So for those of you who aren't familiar, ROHHAD is an acronym for Rapid Onset Obesity, Hypothalamic Dysfunction, Hypoventilation, Autonomic Dysfunction. The hypothalamus, for that H in ROHHAD, is a tiny center in the brain that plays a large role in maintaining our body's normal homeostasis. So when somebody has hypothalamic dysfunction, they They can have rapid weight gain. They can have problems with their water and salt balance. And thankfully, Marissa hasn't had any of the issues with growth or puberty at this point, but it's one of the things that we need to be concerned. Now, the main difference with ROHHAD syndrome is that the hypoventilation isn't due to a problem with the lungs. It's the signal from the brain is not able to respond appropriately when Marissa should be normally breathing faster. The autonomic dysregulation, which Dr. Weese-Mayer is going to go into much more detail about, could include all different abnormalities such as problems with the eyes, increased sweating, different body temperatures, changes to the heart rate. So before the Carneys went out to Chicago, Dr. Weese-Mayer had asked for some genetic testing to be done. There's no gene that can be used to say, yes, you have ROHHAD, no, you don't have ROHHAD. But one of the tests that is often looked at is a gene called FOX2B, which is seen in a similar syndrome with congenital hypoventilation, but is not seen in ROHHAD. She also had some baseline studies done that thankfully were all normal. At this point, I finally met Marissa, and the reason she came to see us was that she had still been urinating a lot, and although the family had been instructed to have her drink up to 50 ounces a day, Marissa simply couldn't drink that much. So the parents wanted to find out if we can continue to try a medication called DDAVP, which is an anti-diuretic hormone to try to help regulate her urination and increase thirst. We decided to give it a try, and thankfully we've been doing a decent job of keeping her sodium somewhat steady. Marissa first went out to Chicago at about 4.5 years old, and at that point she was noted to have increased sweating, she was complaining about constipation, the rapid weight gain, increased appetite, and at this point maybe the DDAVP was doing too well of a job because she needed to be reminded to drink. It was noted that her pain perception wasn't the same as that of another child her age, and she also had increased anxiety. I guess they didn't want to keep the DDAVP going. They tried her off of it, and her sodium went up even higher than it had been initially. And they started to do more sleep studies, which really showed that she was having a lot of problems with her breathing while she was asleep, and recommended that she go home with a special monitor to see her respirations while she was asleep. And at that point, it was confirmed that ROHHAD was what she had. After she left the Chicago Center, we started testing her sodiums at home and made adjustments to her DDAVP. But over the next few months, her sleeping became more and more irregular with her respirations. She began to snore. No longer was just the end tidal monitor enough. She needed to get special breathing apparatus called BiPAP to prevent her from stopping breathing overnight. And she started to have lowering of her oxygen levels during the day. And as you can see, this happened over really the span of about 3 to 4 months. She went back a few months later to Chicago, and there they found that, again, her respiratory status was really rapidly deteriorating. As such, just a few months later, it was decided that in order to prevent her from having complete respiratory failure, it was in her best interest to have a tracheostomy tube placed so that she would not be deprived of oxygen. Over the next few months, she went back and forth to Chicago, and unfortunately, due to the nature of the disease, her respiratory status was continuing to worsen. She was gaining weight, which also made it more difficult for her lungs to, her chest wall to move. Her cardiac exam started to change. When it had been normal preoperatively, she started to develop a fast heart rate, and there was some abnormal patterns in the Holter monitor that she wore, and it was thought that this might be part of that autonomic dysregulation. Her cholesterol kept on rising, and she was ultimately started on medication to lower her triglycerides. In terms of the endocrine findings, which is my particular area, again, she was continuing to gain weight excessively and very hungry. And I really give the family a lot of credit because they really have been very, very strict in limiting her calories to about 1,000 calories per day. She was found to have an elevated TSH level, which suggested that her thyroid gland wasn't working as well as it should have been. And again, we tried to optimize her medication levels to keep her sodium stable. You can see though that through this all, Marissa never ever stopped smiling. And when she went back for her 4th visit, her ventilatory settings continued to be adjusted. She was started on thyroid hormone replacement. Thankfully though, by her 5th visit, even though she was requiring the mechanical ventilation, there was some improvement in her autonomic dysfunction in terms of that variability to her heart rate and her cerebral autoregulation. By the 6th visit, there was continuing to be increased improvement, and it was determined that she didn't need to be connected to the vent all day. She was allowed to breathe for up to 2 hours a day with just a little bit of extra oxygen. By her 7th visit, her respirations continued to improve. Her body temperature started to respond more to the environmental temperature around her. She didn't need as much respiratory support. Her heart rate variability improved, and her blood flow during sleep and wakefulness to her brain also was improving. By her 8th visit, there was continued improvement. She was able to make tears. The constipation wasn't as much of an issue. She used to come in and be like, look how cold and swollen and purple my hands and feet are. And that was getting much better. And she was starting to recognize, changes to the temperature around her. They had decided at Chicago to add in caffeine to try to help her respiratory status. And at that point, she was able to go up to 5 hours without being connected to the vent. By her 9th visit, she was able to go up to 7 hours a day of breathing on her own, and there was continued improvement in all of her other vital signs. And she's been able to hold on to her urine and experience thirst. And this past weekend was Marissa running at the ROHHAD fundraiser run, so clearly she's doing amazing. I'm not going to go into too much detail because Dr. Weese-Mayer will, but ROHHAD, it's also known as hypoventilation autonomic dysregulation with neural tumor, late onset central hypoventilation syndrome with hypothalamic dysfunction, or some people say it should be called ROHHAD-NET because of the association with neural tumors. So it's a very rare disorder that was first recognized in 1965. I don't even know if truly 100 children have been identified. And really with this disease, the children have all been seemingly healthy and normal for the first 2 to 4 years of life with sudden onset of symptoms. What's really amazing about Marissa's case, and I'm sure Dr. Weese-Mayer can talk more to this, is that most children are found to have ROHHAD syndrome after they've already experienced cardiopulmonary arrest, whereas with Marissa, thankfully, things were much more proactive in going ahead and really helping her to get the support she needed before coming to that. The real key feature is the rapid weight gain of about 30 pounds or more in 6 months period. Also the constellation of findings of the dysregulation of the respiratory system, hypothalamic dysfunction, and autonomic nervous system. So this here sort of just shows Marissa's growth curve from when she was little. So this here is her height curve, and you can see she was progressing nice and steadily. But I will tell you that this is extremely unusual to see this much, weight gain, and that's essentially over the period of a year. And this continues to show what Marissa's growth has been like over the years after her diagnosis. I'm going to let Dr. Weese-Mayer talk more about some of the symptoms, but kind of show off Marissa's gorgeous dress and pictures. So to make the diagnosis, and it features of rapid onset obesity and alveolar hypoventilation, evidence of hypothalamic dysfunction, and absence of this gene that's seen in the congenital hypoventilation. In order to really confirm the diagnosis, it's important to have somebody undergo overnight sleep studies to look for sleep apnea or essential hypoventilation, do imaging of the chest and abdomen to look for those neural tumors, as well as have the child undergo a complete cardiac and endocrine evaluation. ROHHAD is certainly an evolving disorder that requires multidisciplinary care, including not just endocrinologists and autonomic nervous medicine specialists, but ophthalmologists, gastroenterologists, pulmonologists, and psychologists. Obviously, everybody here is in support of the ROHHAD fight, which the Cornys have founded and have done an amazing, amazing job of helping to increase awareness. And really awareness and spreading the word about ROHHAD is what is really, I think, most important to get, people thinking about this disorder, not just, lay people, but physicians as a whole, because otherwise this diagnosis will be missed. I love this picture with Marissa and her family down at the Capitol, getting ROHHAD officially proclaimed as one of the rare disease days. Certainly, raising money is always, always helpful for the cause, whether it's from big or small. And just wanted to thank Marissa and the Carney family for allowing me to share in their journey.
Thank you, Dr. Osipoff. That's Justin Bieber at the bottom left, for those who don't know. That's Marissa blushing like I've never seen her blush. That was a good day for her. Next up, I'd like to introduce Dr. Weese-Mayer. Without her, a lot of the stuff that you just saw doesn't happen. The quality of Marissa's life really is determined by the decisions that they make in Chicago, the settings on her ventilator, all that good stuff. That all comes from Chicago. As much as we love our doctors in New York, a lot of them don't understand mobile patients with ventilatory care, and they do a wonderful job out there assessing, and Dr. Weese-Mayer will tell you a little more. Here she comes.
Can you hear me? Yes. You're awake? Okay. Yeah. Can you still hear me or no? Yeah? Okay. Well, the most important thing is what a privilege it is to get to know Marissa and Danielle and Billy. In all the years that I've been in academic medicine, I have never met a more inspirational family. And ROHHAD is without a doubt one of the toughest diseases that we investigate in our center. And I think all of you are here because you know how amazing this family is, but it's important for me to say that publicly because you are our heroes. And Marissa is my superhero. So with that, Jennifer did an amazing job. You'll tell me if you stop hearing me, right? Because this ruffle thing is having trouble with the microphone. I wanted to call this ROHHAD 101 because the most important thing we can do is impart to all of you a passion for understanding this particular rare disease. It's a very special rare disease, and it's super rare, as we say. And Jennifer told us that there are about 100 children in the literature. We know there are many more children in the world, but there are a lot who just escape identification. When you leave, you will all be experts in ROHHAD, and you will be shocked at how many times you will call Danielle and Billy and say, I think I found another child. Because really, if you have the passion enough to be here and to be friends with this amazing family, you'll catch on really quickly. I am indeed at Northwestern, and I am proudly the new Cummings-Mayer Professor of Pediatric Autonomic Medicine. Jennifer alluded to autonomic a little bit. The easier way is to think automatic. The autonomic nervous system is a system that functions automatically to keep us healthy and alive. It makes sure that our heart rate and our breathing and our temperature and our blood pressure are all integrated. And it's because of that passion that we actually got hooked on ROHHADs and have worked so hard to understand it. It is a new and emerging discipline in pediatrics, and this chair at Northwestern is actually the first one in the world in pediatric autonomic medicine. So you already saw the acronym. To be honest, and I'm a full disclosure kind of person, we came up with this acronym at our dinner table because we were so frustrated at how many doctors missed this diagnosis. And in the paper that we published in 2007, and I'll back you into that, we could identify very characteristic features of the children we were privileged to see. Back in the day when medical record actually was on paper, We literally made piles of all of the different symptoms in child number 1 that was similar to child number 2, and before long we had all of these features, this rapid onset weight gain, and features of hypothalamic dysfunction, and hypoventilation, and autonomic dysregulation. So it was going to be called ROHHAD, but our son, who's now 28, he was a young adult, let's say. He explained that A.A. Milne would not have thought it was really cool that Roo belonged with Winnie the Pooh. So we hyphenated the rapid onset, so it became ROHHAD, and a little easier for people to understand. So I want to talk about ROHHAD first in the context of other disorders that have at their core respiratory and autonomic disorders of infancy, childhood, and adulthood. When we say respiratory, most people think of cystic fibrosis or asthma or more common diseases. When we say respiratory control, we mean do you breathe or don't you breathe? Do you respond to high carbon dioxide and low oxygen? And so the diseases shown in these puzzle pieces on this slide are all disorders, either we know that they have dysfunction of respiratory control and autonomic regulation, or we suspect that they do. The two that are circled here, CCHS and ROHHAD, are definitely the most severe in terms of respiratory phenotype, and they both require supported ventilation. To digress for a second, CCHS, and I have to admit I'm a big acronym person, so get used to it, sorry. CCHS stands for Congenital Central Hypoventilation Syndrome. It's a rare disorder, but when we say rare, we're talking 1,200 people identified since 1970, not 100 people identified since 1965. It's because of our experience and expertise in CCHS that when we met our first patient with what we now call ROHHAD, we felt like they were cousin diseases. Because the kids with CCHS hypoventilate, they don't respond normally to carbon dioxide and oxygen, they can have tumors of neural crest origin, but they rarely have any hypothalamic abnormalities. So we felt very much at home with the symptoms that we identified in children like Marissa, but we also felt a need to understand this quote-unquote new disease. So the history actually dates back, and Jennifer shared that with us. 1965, Dr. Fishman in California described the first case. He got the name a little bit off. He called it primary alveolar hypoventilation syndrome, and he called it Ondine's curse, which in the dinner hour, if anyone wants to know the story of that German folk epic, I'll share it with you, but we do not use the term Ondine's curse for ROHHAD or for CCHS. And he described the hypothalamic disease in these children. Well, over the ensuing years, people didn't like that title. They actually stole it and used it for CCHS. And they used an even worse name of late onset central hypoventilation syndrome with hypothalamic dysfunction. I mean, I'm into acronyms, but that one was really bad. So by 2000, our colleague Elliot Katz described one case report and reviewed the only 10 cases in the literature between 1965 and 2000. And Elliot proposed that this disorder, with a variable name, was distinct from CCHS. Well, in 2003, we and others described there's a gene called paired-like homeobox gene, the FOX2B gene, that was the disease-defining gene for CCHS. And we could show that children with what we call ROHHAD did not have mutations in that gene. So finally, we could say that they're cousin diseases, but they're not the same disease. In 2007, after months of sitting with medical records and making lots of piles and coming up with the name at our dinner table, we created this acronym and published the seminal paper and showed very clearly that there were no FOX2B mutations in children with ROHHAD. This is just the front page. It was a lot of us working together. We often reach out to other investigators if we can't do something. And so it was several of us from not only our program in Chicago, but also a team in England that did some of the work with us to publish this paper. And it was shocking to us, the visibility that we got. We thought we were just passionate about ROHHAD, but we, from that point on in 2007, are continuously contacted about children who may or may not have ROHHAD, but at least it's on people's radar. And I have to say, the other hero of mine is Jonathan Fish, who's Marissa's oncologist, who was so meticulous in his history taking, and it wasn't a big amount of weight, but Marissa's mother thought that it was abnormal. And Jonathan called me and said, "You've got to get this little person in." And I don't think we've ever moved that fast. It probably didn't feel fast to Danielle and Billy, but on camp time, it was definitely fast. And we've learned so much that we can give back to Marissa because we got in very early on her story. That's not the case, unfortunately, for most of the children. So as Jennifer described, there are different features of the clinical diagnosis of ROHHAD, and the key issue is this rapid onset obesity. If you have a 4-year-old, and I think some of you in the room probably have had small kids or have them, a 4-year-old weighs 40 pounds. Well, if you're 3 years old and you gain 30 pounds in 6 months, that's immediately obvious. What we found as we were describing and making the new acronym is a lot of pediatricians said they just eat too much. And look at the family. Well, families of children with ROHHAD are not overweight. Families of children with what we call exogenous obesity often are overweight because the cooking style at home just puts too many calories on the table. So we are desperately in need of pediatric endocrinologists like Dr. Osipoff who recognize what's different about these children. The hypoventilation is also key to the diagnosis. And then the hypothalamic dysfunction, what we observed is at one visit, like when you first meet the child, the kids may just have the rapid weight gain. But you have to keep following these children because it's a diagnosis that unfolds over time. And those words on the table that probably look like mishmash, and I don't know if you can even see the words in the back, but they're different aspects of the hypothalamus that can be abnormal in these children. And then the other part of the diagnosis is an absence of a CCHS-related FOXP2B mutation. But the big message here is there is no diagnostic test at present to tell us that a child has ROHHAD. It's all based on our experience going through medical records endlessly and evaluating the children in our laboratory. We were in that same place in 2003 with CCHS, but by matching up the FOXP2B gene to the diagnosis of CCHS, we've made major progress, and that's definitely our expectation of what we can do with ROHHAD. So the blind man describing the elephant, and Jennifer had a great slide, although I got the elephant in mine, showing all of the different subspecialists who might encounter a child with CCHS. The problem is the way healthcare is today, if you get 20 minutes with your doctor is a lot. And unless it's a very observant parent, some of these children are missed until things are a little too late. So I want to walk you through the acronym to make sure that you get the whole picture. The rapid onset obesity, you actually saw the growth chart for Marissa, which is very, very striking. There is no other disease that puts on weight at that kind of trajectory. This slide is looking at the first 15 children that we saw. So each horizontal line is a different child's. And where there's a red oval is where the timing was. The horizontal axis is age. So the timing relative to their phenotype or clinical features that the rapid weight gain occurred. And it's nearly always the first feature. And sometimes we say that it's a harbinger of things to come, but the important thing is for people to be alert to it. And then this is a growth chart showing two children. They happen to be identical twins, but they're discordant for ROHHAD. The blue lines are the child with the ROHHAD, and the green lines are the child who doesn't have ROHHAD. And if you look at the pictures with advancing age, you can see when they became more and more obviously distinct from one another. So the hypothalamic dysfunction, I lean on people like Jennifer a lot because these just happen to be features from those first 15 children of different kinds of hypothalamic dysfunction. But if you think of the complexity of the hypothalamus that keeps us afloat, it balances us, it provides homeostasis. This slide and the next slide are all different aspects of the hypothalamus that integrates aspects of control of breathing, all kinds of important hormones about water balance, all the things that we've described already for Marissa, but also temperature regulation, vasomotor tone, like those cold hands and feet that Jennifer mentioned. All of these components that we know in ROHHAD are integrated within the hypothalamus and more. The hypoventilation is definitely something that I was brought up with. I did a control of breathing fellowship. I mean, you want to talk esoteric. It got really esoteric there, but it comes in handy when you have a disease like this, because all hypoventilation means is shallow breathing. We tend to think of hypoventilation in terms of the size of the breath, not the number of breaths in a given minute. What you see in blue are the timing of the hypoventilation being identified. We suspect that the kids actually are hypoventilating long before the time anyone actually notices it. But because the kids don't have normal responsiveness to low oxygen or high carbon dioxide, they may well be terrific underwater swimmers because they can hold their breath longer and swim farther than anybody. And that actually is how some of our kids were diagnosed. And we had a coach who unfortunately was telling a child that she wasn't swimming fast enough and she wasn't swimming hard enough and she should be taking off more weight. She got a chest x-ray and she had a huge tumor, and which was removed, and she definitely has features of ROHHAD. So this slide is just spending a couple of minutes on the concept of disordered respiratory control. When we say responsiveness to hypercarbia, that's carbon dioxide, and hypoxemia, that's oxygen or low oxygen. And some people, when they even go up in an airplane, feel uncomfortable and they might feel kind of anxious because the oxygen content in an airplane is reduced compared to the air that we're breathing sitting here at, well, I guess sea level. I know we're in New York, but I'll try to be careful and not say anything else. I'm from Chicago. The disordered respiratory control in kids with ROHHAD is not quite as severe as in the kids with CCHS, and we actually just published a paper describing this. The problem is separating out the obesity from the control of breathing deficit, and that's something, again, that's our responsibility to make sure we teach people properly, but it also slows people down on identifying these children. We also know that the breathing component of ROHHAD varies as the clinical features of ROHHAD unfolds. And Jennifer was describing that, how Marissa seemed to become more severely affected. Initially, she didn't have a trach. She didn't need a ventilator. And then very quickly, she tumbled down into that foxhole of needing mask support and then trach support and then 24-hour per day support. But over time, her awake breathing has improved. And that's all part of the issues of control of breathing. The other striking thing is kids with ROHHAD lack behavioral awareness of asphyxia. So if they were to swim, the reason they can stay down longer and swim longer is they don't sense that panic that we would sense if we were down under the water for that long. So when someone comes into our lab with a lot of blue ribbons for swimming, we're already suspect. So the tracings that you're seeing here, these are the different channels that we would record in our laboratory. And the top channels have to do with breathing. And then the next channel, the one that's got the rectangular shape, so the fourth channel down, is exhaled carbon dioxide. And the next couple of channels have to do with oxygen, and then airflow, and then those of you who watch doctor channels, you'll recognize the EKG, and then blood pressure with the pulse waveform from a little finger probe. So when the kids are in our lab, we look at all aspects of their breathing, of their autonomic regulation, and many aspects of their hypothalamic function. We also measure, you saw in one of those pictures, a little something on Marissa's forehead. And what that is it lets us look at regional oxygenation or blood flow, because we need to be able to understand what symptoms the kids are describing. And just because some things by traditional means look okay, we look harder and more deeply at other tools, and that's a tool that's usually used in the intensive care unit. And it looks to describing cerebral autoregulation, which Jennifer mentioned. We also look at temperature of the room relative to the temperature of the child. So this is just a schematic looking at how we assess the children's breathing to low oxygen and high carbon dioxide. We have a baseline period, then we bring in different gases through the ventilator, and then we have a recovery period. And not for you to dwell on, but just looking at these different tracings show Marissa's results when she was not quite 4.5 years old, and then her results just a few months later, how dramatically different they were, and that's how fast ROHHAD changes. But if you're not watching these kids, you miss all of it, and they get into terrible trouble. So the diagnosis of hypoventilation is difficult, but it's essential, since it's life-threatening. What you can see with the green circles are the timing of cardiorespiratory arrests in about half of the children with ROHHAD. And what you can see in the purple is a child who is lost. Subsequent to that publication, there have been 2 additional losses in that same cohort. And just driving in today with Billy, he was describing some more children. And our experience has been that it's likely that these losses are because the parents are not, and certainly not the parents who are in this room, but parents of children with ROHHAD who have had such difficulty accepting the diagnosis. They had a seemingly normal child, and then someone is now telling them that child needs a tracheostomy and is at risk for an arrest. The parents are not as willing to do the tracheostomy and to do the ventilator. And sadly, the end result is that the child will succumb to the disease. And that shouldn't happen, and it doesn't need to happen. The autonomic dysregulation is also very much in our thinking every day, and kids with ROHHAD have not only taught us a tremendous amount. From what we've learned, we can go back to improve their care. So the eye findings occurring in almost all of the children with ROHHAD, we actually were able to quantitate with a little handheld tool that you see in the bottom left-hand corner of the screen. It's called a pupillometer. It takes a video of a light stimulus and the changes in the pupil response. And we actually were able to compare children with ROHHAD versus control children. And you can see, if you look at the vertical axis, is the diameter of the pupil, and the horizontal axis is time. And when you shine a light, your pupil gets smaller, and then it recovers. But the kids with ROHHAD seem to have larger pupils, and they don't change in size as much as a control subject. So that's part of our objective measures for kids with ROHHAD, so that we can evaluate their autonomic nervous system, especially when we're going to do intervention trials. This slide is actually just looking at pupillometry results in kids with ROHHAD and kids with CCHS. And the important message is, using pupillometry, you can see that there's a difference between the kids with ROHHAD and the kids with CCHS in terms of different aspects of their autonomic nervous system. The thermal dysregulation, especially for Marissa, who does like to show us how cold her hands are, and often how clammy, and sometimes how purple, the thermal dysregulation is something we had trouble getting our arms around, because in typical medicine, there really aren't tools. So we used something called an eye button and fashioned it onto a little wrist bracelet that Marissa and several children wore, so that we could measure their temperature of their peripheral skin every 3 minutes over the course of a week, awake and asleep. And what we learned is that the peripheral skin temperature in children with CCHS is different from ROHHAD, is different from control children. So on the vertical axis, you're seeing temperature, and on the horizontal axis, you're seeing time. So 8 in the morning till 8 at night are wakeful hours, 8 at night till 8 in the morning are sleeping hours. We all have a pattern, it's called circadian variation. This is peripheral skin temperature, not core temperature. But you can see here, red is ROHHAD. You can see the broad swings in peripheral skin temperature. So by using this research tool, we could start to understand what Marissa's experiencing and figure out ways to actually help her. And the caffeine was one of the ideas that has proven to be very effective for improving her skin temperature. The neural crest tumors, the neural crest is a very early beginning of our nervous system. It becomes your sympathetic nervous system and your adrenals, and you can unfortunately develop tumors anywhere along those anatomic regions. In ROHHAD, many of the children, almost half of them, will have a tumor of neural crest origin, and Marissa had a ganglioneuroblastoma. They can be removed, and usually the kids do well after that. But when it's associated with ROHHAD, it obviously adds complexity. Neurocognitive testing is very important in ROHHAD because sadly, people are under the impression that if a child has ROHHAD, that their intellect might not be as strong as their parents. But that's simply not true. And in this slide, you're seeing the ROHHAD kids have an IQ that's pretty much the national average. 100 is the national mean. Kids with CCHS actually have a lower IQ of 85, which is 1 standard deviation below the norm. But if somebody arrests, their intellectual outcome will not be favorable. So it's critical that we prevent arrests in these children. So who gets ROHHAD and why do they get ROHHAD? Well, sadly, we don't really know. Hard as we are looking, we cannot identify at the front end which of those cute little 2- and 3-year-olds are going to end up with ROHHAD. That's in part because ROHHAD is very rare, and in part because a center like ours, who is now very aggressive at finding these children, has only found 100 potential kids in the past 10 years. It's also difficult because ROHHAD is a very complex disorder. And there's a suggestion that there's an abnormality in neurologic development with a potential trigger. In development, we think of a natural progression, right? We grow taller, we grow more capable, but there are certain genes that should turn off at different stages and certain genes that should turn on. And in ROHHAD, we firmly believe that that's where the basis is going to be. The other issue is with so many specialists involved, often there's decentralization. And so lots of people who could be looking at lots of children with ROHHAD are not. A subset will be looking at their different part of ROHHAD. So in searching for answers, there are 3 categorical regions that we've gone in terms of research. One is alteration of early neurologic developments. And for that, we think in terms of genes that are involved very early in respiratory control, autonomic development, and hypothalamic development. Well, we and others have done candidate gene evaluations. We would figure out what genes are expressed where and when, and study those. And many are shown on this slide, but the summary statement is none of these are the magic bullet. None of them are the disease-defining gene for ROHHAD. So thanks to the support of ROHHAD Fight Inc., we have done very sophisticated genetic studies looking for copy number variations, doing very deep exome sequencing, the part of the gene that determines the protein. And the important answer, and we have a paper that's about to go in, is that even this sophisticated technology has not given us the answers to ROHHAD. We are now actually, and I'll go into this in the last slide, doing whole genome sequencing again, thanks to the support of ROHHAD Fight Inc., where we do feel very strongly that the answer is going to be there. Because with the diagnosis, we can actually be much more aggressive in identifying children. A paraneoplastic phenomenon has actually been very popular in terms of thinking for ROHHAD. And that's because in years past, children not with ROHHAD, but who had a neuroblastoma or other kinds of neural crest tumors, people thought that those created an autoimmune situation. But we know that even when the tumor is removed, the kids continue to develop the features of ROHHAD. So this path actually has not been so appealing. And then epigenetics, or the environment of the genes, which as we grow older, we have more and more environmental exposures, might be a possibility and maybe a relationship to other of those radica disorders, but we're not there yet. So in terms of management, for us, it's all about keeping the kids safe until we get to the bottom of the genetic basis. We make sure that these children are properly supported because our big goal is to optimize neurocognitive potential for the kids. And everything focuses around that. So when Billy said changes in the ventilator, things that we do automatically, that our breathing changes when we go to sleep, these kids don't have those changes. Or when we exercise, these kids don't have those changes. So we do all of that to make sure that the kids are always well oxygenated and always well ventilated until they're at a point where they can do that for themselves. This is a multi-system disease with multiple specialists, and this is one that shows all of the different places where a specialist or a generalist might meet a child with ROHHAD, but we know that they just don't know enough yet. So my last couple slides are to tell you what we've done with the support from ROHHAD Fight, Inc. We've developed an international registry so that we can characterize the natural history of ROHHAD. We've already identified 80 families and enrolled 40 of the families. And we're in contact every 6 months so that we can know what happens based on management. We can teach from not so good management, and we can teach from great management. I founded an international ROHHAD research consortium. We have 12 investigators, and we've created a DNA bank from 40 children, their parents, and their tumors, so that we can do all of those genetic studies that I described to you. We've done the copy number variation and the exome sequencing. We've reported on the ventilatory challenges, the responses to carbon dioxide and oxygen. But what are we doing next? Because we're never really satisfied with what we're doing until we have the answers, and even then we're not so satisfied. But as I mentioned, we're doing whole genome sequencing of the blood and tumors from kids with ROHHAD and their family members. This is hugely expensive, and actually the most recent generous gift is allowing us to accomplish this project where we really feel that we will find what we are looking for. We're expanding that registry to make sure that families all over the world participate. We recently received a grant to look at fibroblast cultures from skin biopsies from children with ROHHAD. We're developing these into stem cells, and then from there we're studying organ-specific cells. So working backwards from basically a cell culture situation to understand what ROHHAD is so that we can translate that back to the clinical care of the children. We're formalizing more of the autonomic characterization and the neurocognitive testing as our platform before we begin intervention trials. We are formally describing the recovery phase that Jennifer described so clearly for Marissa, but unfortunately everyone doesn't get that or understand that. And it's vital for parents of newly diagnosed children to know that that definitely can happen. And we are in the process of preparing anticipatory management guidelines. So just as for CCHS, we could tell doctors and parents what to expect and what is expected of them to totally optimize the care for their child. And we're working to enter ROHHAD into the National Institutes of Health Global Rare Disease Registry. So given the devastating nature of ROHHAD and the fact that genetic risk factors at the superficial level haven't given us answers, it's vital that we investigate other possible mechanisms of disease. And we expect that those findings are going to take us to helping understand how Marissa, as a 2 or 3-year-old shown in the picture on the left, how she transitioned into this remarkable condition. And our biggest goal is to understand ROHHAD, translate back to the families and children, and to decrease the disease burden that families of a child with ROHHAD are faced with every single day. This is a slide showing all of our collaborators who have worked with us on these projects, and Jennifer used the same slide, but I have to tell you, Marissa and her family are the most amazing heroes. It doesn't matter how many doctors, how many nurses, everybody else. The real heroes are the kids with ROHHAD and their parents. And seriously, how many of us would go to the point of working with their capital to get a month, a day, anything, even an hour, but to get the awareness for ROHHAD that Marissa and her parents achieved? So I think all of us should think about raising a glass to Danielle and Billy for all of the work that they've done in honor of their child and in honor of children all over the world who have ROHHAD. Thank you.